Stephanie, so much. So moving from our first slide, before we get going, we'd really like to position ourselves and where we're presenting to you from today. I myself am at McMaster University in the McMaster Children's Hospital. These are both on the traditional territory shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. I have so much debt to all of my Indigenous neighbors, colleagues, patients, families who have spent so much time teaching me along the way. And my hope moving forward is that we can move ahead with good minds and right action as we improve our relationships with our Indigenous neighbors and patients.
Thanks, Stacey. And my name is Carolyn Way. I'm a first-generation immigrant settler to these lands, and I'm presenting today from Toronto, which is located on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis. The City of Toronto is covered by Treaty 13, signed with Mississaugas of the Credit, and if you're in Scarborough, east of Woodbine, Williams Treaty, signed with multiple Mississaugas and Chippewa bands. So, as I said, my name is Carolyn Way, and although I started my career in public health nutrition, the bulk of it has been spent in health equity. So for about 14 years, my job was as a health equity specialist with Toronto Public Health. And in that role, I trained hundreds of multidisciplinary public health staff in what we called mandatory access and equity training. I also developed inclusive program planning tools, equity-based performance measures. If you're in Toronto, I was also the lead researcher for one of the lead researchers for the We Ask Because We Care project, which was a research project to develop and test a pilot set of sociodemographic data questions. And those data questions then provide the basis of the mandatory set that all Toronto hospitals and community health centers had to collect in what's formerly known as the Toronto Central LHIN. The other reason why I'm here is actually as a person with lived experience. I know Stacey would say that's not the reason why you're here, but the other reason why I'm here is because I am a parent of a child who had cancer. And so I also bring that perspective. It's a little bit discombobulating today because this is like where my two passions kind of intersect, which is equity and better outcomes and care for children with cancer. And on to Stacey.
And I'm Stacey Margeris, and I imagine many people in the audience and I have interacted as my daytime job here at MAC is as a pediatric oncologist and medical director of the Late Effects program here at MAC. In addition, a lot of the research work and my passion is in caring for marginalized children and looking at sociodemographic determinants of health and malignancy. Some of my early work as a fellow included looking at outcomes for Indigenous children with cancer, and now thinking about that relatively broadly as I've worked to create relationships with families and with community members in the hopes that we can improve care. We think a lot in oncology about adding this medicine and adding this approach to therapy that changes outcomes by a small amount. And I think one of the things we need to really think about is making sure that everybody can come to their cancer journey from an equal playing field or from an equity perspective, so everyone has access to the same good care, because that really can narrow the gap for a lot of families. So thinking about our objectives for this session, we're going to introduce some basic concepts of health equity, social justice, and the application of anti-oppressive practices and how that applies to cancer care and to research in the pediatric cancer sphere. We'd like you guys to gain some familiarity with the research guidelines on collection of data for equity deserving groups, so things like OCAP and EGAP, and learn how to apply this information to the research that you do, using some of what we're doing here at the CPCC or at ACCESS as an example.
Okay, so we're just going to start off with, I don't want to say an easy question, but easy in the sense that it's not going to track your name. So if you wouldn't mind opening Slido, either through the QR code or through the website, and the code is there, 2400272. And the question we want to ask you, and can type it, is how does health equity intersect with the care of Canadian pediatric cancer patients? Somebody started us off with inequitable access to novel agents. And you can write, I don't know. It's okay to say you don't know, and you're here because you wanted to learn a little bit more about it. But we wanted to kind of just see where the audience was at in terms of their knowledge about how health equity might intersect with pediatric cancer in Canada. So you see 8 participants typing. Experience for family and distance to a tertiary center. No idea. Very honest answer. Levels. So I see remote, so geography. Someone said, I saw a graph that shows difference in survival at COG, and Stacey's certainly going to show you some more slides. Families who can afford to travel and take time off. Absolutely. The funds income is certainly an aspect of health equity. Geographical distance. Who's included in research? There's some really great answers already in here. An experience for family. Lack of siloed service, oral take-home drugs. Okay, so that's great. I think there's just, I'll let the last couple people finish typing. Parent understanding. And, you know, just as the last person's finishing off, like, I'm not an expert in health equity in pediatric cancer. That's probably Stacey. But I do appreciate these answers. And what I'm going to be focusing on in the next set of slides, given the amount of time we have today, are just some key points that I'd like you to take home with before I pass it over to Stacey and her set of slides that are a little bit more focused on pediatric cancer and research. Thank you so much again to everyone who had them. But I'd like to focus on some key points in my set of slides and some tips about how to start incorporating this particular area. Sorry, I'm just going to let the last person type. So no idea came out quite high. A lot about distance to care, geography, removal of fear for speaking up, cultural sensitivity. Yeah, all of these fit into the realm of health equity and how it intersects with pediatric cancer.
Now, I just want to point out mistrust. I think that's a huge.
Oh, I didn't see that one. Thank you.
Yeah.
Okay, and sorry, the last one I did see was involvement in decision making, which I'm going to get to in my slides. Okay, sorry, we can move on. So a lot of people like to ask for definitions in these types of talks, and I do apologize because I am in Toronto and the bulk of my work has been in public health and in Ontario. Some of the definitions I pulled are Ontario based. So this one, you'll see different definitions of health equity. This one's from Public Health Ontario. It's not that much different from the WHO. Health equity is created when individuals have fair opportunity to reach their fullest potential, and achieving health equity requires reducing unnecessary and avoidable differences that are unfair and unjust. And so you'll probably have seen, oh yeah, you can move on. You've probably seen this classic pictures, at least the first 2 pictures of what are we talking about when we talk about health equity, this idea that everybody gets the same versus kind of like an economic approach of, well, if we just redistributed resources to those in need, we would achieve equity. And I would say that's part of equity, like this idea of like, do you translate resources? Do you provide meals for parents while they're watching, while their child is in care in hospital? Would be part of those kind of shuffling of boxes. But really what I would call that is equitable access to healthcare. It's a component of equity. This idea, if we think about looking over the fence, is about equitable access to the actual healthcare, but it's not real equity. Right. So if we think about the second half of that definition from Public Health Ontario, it talks about steps. Like health equity to me are the steps of reducing health inequities and those are those health differences that are unjust, avoidable, and unnecessary. So what you're talking about is access to social determinants of health, and we're talking about oppression, the social structures that people already come to. So the third picture is really about reality. Right? We're not talking about that they're even on the same piece of grass. There might be a hole, a trench that's in there. There might be so many boxes that we're not even allowed to redistribute. So it's nice in theory to think that structurally in our society, we're all in the same starting place, but really we're not. We're in this different type of reality. And what true equity is about social justice, where we're thinking about how do we actually dismantle the fence, and that it takes each of us consciously deciding that we want to participate in the dismantling of the fence, and the fence being societal and systematic oppressions in our world. And so what do I mean by that? And these are the last two definitions I have on my slides. Is when I talk about oppression, I'm talking about institutional power, that these structures that have been formed over time that benefit certain groups, whether intentional or unintentional, to the disadvantage of other groups. And that's typically based on race, but it can be based on other social identities. And then therefore, when I talk about anti-racism, or in this case, the title of the presentation, anti-oppression, I'm talking about that active process. Like, how do we actually change and dismantle at an individual, institution, and systemic place all these different oppressions and the impacts they cause on people? Next slide. So I've already mentioned that I used to train public health staff on health equity and access and equity and inclusion principles. And a dear colleague, Eric Ng, and I, when we kind of left those roles, we still wanted to do this work. We wanted to make an impact, in particular, because ironically, he was also a dietitian working in health equity in our field, which was dietetics. And so we spent a lot of time talking about how do we get people to move from box number 2, which is, we would hear things like, if you could just tell us what my client eats, I could learn that and therefore provide good service, to thinking about box 4. And so where we landed was a conscious decision that we didn't want to talk about health equity anymore because it had been co-opted into a conversation about how do we just provide access to resources, that we actually wanted to talk about the dismantling of the fence. And so what we came up with was a definition for an anti-oppressive dietetic practice, because we didn't have one for our profession. And it's based off of, if you look up anything around anti-oppressive practices in health and caring areas, they're typically rooted in social work. And so our principles, I didn't give you the definition, but I gave you the principles of practice, are based off a social worker named Donna Baines. Like a lot of research comes from Donna Baines around anti-oppressive practices. And so the 4 that we talk about in our paper is recognizing your own power and privilege, naming racism and oppression, and acknowledging and amplifying lived experience, particularly those of oppression, and advocating for social change. And I think these 4 principles still apply for pediatric cancer care. So you might have come because you were like, oh, I actually want to do this, or you're like, I don't even know where to start. So again, given the time, I'm just going to give you some basic places to start. So where to start? You want to do this work. The first thing you need to do is you're going to have to understand your own power and privilege. And maybe for some of you, that's not new, but that's still step 1. I want you to think about how do you educate yourself, and you could read, there's lots of books in this particular area, but there's also lots of free courses if you need that type of guided kind of piece of work. I want you to think about your practice. I think there's different people on the call today, but to think about your practice, whether that's clinical practice, research, or a program that you deliver with a health equity lens. And I'd be remiss if I didn't say, I want you to involve people with lived experience. And in this instance, I'm talking about families and survivors that are impacted by pediatric cancer, but also those of us who have lived experiences as equity denied communities. And then once you've done those 4 things, start all over again. So the first one is about power and privilege. And you might be, again, where do I start? But some of you, this might not be new. There's a basic exercise. A few of you have heard me speak about it, which is the power flower. There's variations of the power flower. This one coming from the Building Competence website. I like this one because it's clickable. It'll take you a few minutes. It actually tells you what to do. And it gives you some reflection questions as well. And really what it is a self-reflection process to help you identify your social location for each of these petals or identities. So whether you're in the dominant group, therefore you have slightly more power and privilege, or the less dominant group, you have less power and privilege, and possibly you're marginalized in certain spaces. And what you find is that for all these different petals, you have different points of power and privilege depending on the space that you occupy. And if I were training you and you were a set of students, I would now have asked you, tell me there's a space. If you look at the picture, there's a space, a blank petal. I would say, what petals are also missing? But the two that I'm going to just tell you are relevant for pediatric cancer is one, Indigenous identity, and Stacey's going to talk a little bit more about why that particular identity is really important. And the other one is being a health professional. And I think some of you probably know that you occupying the space of being a health professional, even a research coordinator, somebody who looks to be a position of power in the care of someone's child or in the care of that child, already has a different type of power imbalance. So as I said, this is like the most basic introduction step to understanding a little bit about what anti-oppressive practice looks like, because you have to start with yourself. So the next one, I just kind of gave you a certain amount of trainings. I was thinking today I should have given you some books, but we can always come back. But these are trainings that are available. Most of them are free. And I'm just going to tell you what they are so that you can, because I gave you a variety. Somebody said, well, what's a good training I could take? I would say I couldn't come up with one training because you kind of have to cobble them together. So the first one, it comes from the Ontario Human Rights Commission. They offer a variety of kind of basic 101 training on racism and discrimination. They're about 30 to 60 minutes in the modules, and they just give you a good baseline of like, what are we talking about when we say racism in the workplace or racism in society? The next one comes from the federal government. It's called the Gender-Based Analysis Plus. So if you were a federal worker who was in charge of writing a new policy, you're supposed to have taken this training so that you walk through your policy and you take a look. Originally, it was about women. How does your policy benefit or disproportionately impact women? And what they did was they expanded it to talk a little bit about those same social identities that I was talking about in the Power Flower. So it's a good kind of like, you know, some of it the examples might not be great, but the concepts are still the same. Like it makes you think about, you know, I'm running this research program or I'm running this aftercare program. How does it actually impact disproportionately these different groups of people? The third one, if you have not taken the ACCESS Indigenous Cultural Safety Training, I mean, it should have been number one, but I put it number 3. You should definitely take this training. It's predominantly an online training. It comes out of BC, but it is across, there's several kind of centers as well. So Ontario, I think you can take it as an intact in-person training. This is the only training that does come with some costs, but in some centers, it might actually be free because your organization might have pre-purchased specific spots. When you finish the 101 training, it opens up other modules that you could possibly take. Like they have an anti-bias training, for example. It was really, I don't know if they still offer it, but that anti-bias training was quite good. If you came because you're interested in health equity and social determinants of health, then I would suggest that you should go to the National Collaborating Center for Determinants of Health and learn a little bit why I get passionate about health equity. I said you should use a health equity lens. And so there is a tool for that as well. The Ontario Ministry of Health has a health equity impact assessment. What I've given you is the link to take a course on how to actually use that. And again, it's a tool that it's been used quite extensively in public health and community health. Not so sure about clinical, but the concepts would be the same. Again, it kind of walks you through all these different communities or populations and makes you think through about your project from that perspective. And finally, you're like, okay, CPCC keeps telling me to collect sociodemographic data. I'll do it, but I don't know how to do it. And will people even fill out these forms? Will people give us their race information? There is an archived website that was set up by the Toronto Central LHIN when they mandated this data collection. It still has really good tools. It has consent language. It has sample modules with videos. You don't have to start from scratch. So finally, so I can give Stacey enough time, I want to leave you with some sample reflective questions, because what I'm really talking about is like really reflective practice. You've done the Power Flower. What would be the next step is to think through about the demographics of your population. You should ask yourself, like, how do we know if there's any inequities if we don't collect sociodemographic data? So my next question to you would be, do you collect sociodemographic data? Is it standardized? Is it good quality? What's the response rate? Is it self-reported? This next one, does my organization provide translation and interpreters? I did talk about the boxes. But if I needed a translator, do I use my patient to translate to their parents? And I just want to pause here that it is well known that immigrant children are often called upon to translate for their parents and grandparents in a variety of settings, including health, and I should not have been, but I was, that through my participation in CPCC or ACCESS, that I've come to learn of actual patients, pediatric patients, who have been asked to translate their own roadmap to their parents so that the parents could make decisions about their care. And I want you to kind of sit with that and think about the power flare and what we've asked that particular patient to do. Similarly, along the same lane, researchers who are engaged in families, I don't care if they're not the nurse or the actual oncologist, I would like to see them trained in cultural safety. And that's the intersection of my identities, that I would have just said cultural safety before cancer. And now I would tell you, you must have them trained in trauma-informed practice. These are people who've probably gone through the most traumatic experience of their entire lives. And you don't know when a question, the manner in which they're asked, is actually going to trigger somebody. So again, about trying to reduce the amount of harms that we do to these families. And finally, does my organization have a data governance structure? And on that one, I'm going to not say anymore because Stacey's going to cover that.
Well, I'm gonna start. So one of the first items that Carolyn asked us to look at is what are the demographics of our patient population? What do we know? Well, we know that racial and ethnic background is associated with cancer outcome, and we have known this for a long time. So the first graph that you see up here at the top is from an ALL study that collected data between 1983 and 1989. We have known for a long time that kids who are self-identifying as white have better cancer outcomes than other children. And this has persisted. You can see there was a neuroblastoma study from the COG that published similar data. And then in the graphs on the bottom, across male and female patients with leukemia, flipping to the next page with lymphomas, brain tumors, across the spectrum of our diagnoses, we know that there are differential outcomes based on race. And this data was based on SEER data that just was published in the last year. So these things do persist, and they are known and they exist. And you may say to me then, well, this is American data. In the US, different people have different access to the healthcare system. Does that exist in Canada? What about here? Are some kids and youth doing better than others? How do we know? Do some families have better supports and access to care? How do we know why? And there are families across this consortium that have told us absolutely there is different access. This is why this consortium exists, because there was different access for families, and families have advocated for money to put into research to have a national organization so that kids across geographies as a starting point have similar access to care. But do we have this data? Is someone collecting it? Well, we do have some places to which we can go for data. That being said, what's the quality of that data? And so I myself looked at this in terms of outcomes for Indigenous kids in Ontario, and did this work over 10 years ago now, looking at the Pagonis database, where what we saw was similarly that Indigenous kids had about 15% poorer survival from all sorts of malignancies. And this existed across the spectrum of therapies that were inpatient, IV delivered chemos, and outpatient, because often people say, oh, well, maybe it's adherence to therapy. It's not the case if you're getting your prescribed IV chemo. Maybe it's time to diagnosis and treatment, and that didn't appear to be the case. There were lots of questions, and we couldn't put our finger on why this difference existed. But one of the things we did identify was that the incidence of cancer in the kids who were identified in the database as being Indigenous was only about 2%, where they should be holding about 4% of the population at minimum. So either incidence is half everybody else, or much more likely, we don't have people identified properly. And you'd say, well, why is that? And this is where we go back to some of the American work that's done. And this was published recently by the AACR, the American Association for Cancer Research, where they're talking about discrimination as a major barrier to receiving quality healthcare. So individuals reporting discrimination while seeking healthcare, and this is across the adult and pediatric spectrum, was very different by race and folks from sexual and gender minorities. So that's that lime-colored green one. And The second graph here is that individuals avoid healthcare due to fear of discrimination. And so that can be one of the pieces that plays into this puzzle of why our incomes or our outcomes worse. But beyond discrimination, like you're going to look at me and say, oh, in pediatrics, we don't do that. Well, it's just a piece of the puzzle. So that racism, discrimination, segregation feed into structural inequities, social injustices. So it doesn't have to be within the care team that you exist in, but it feeds into this bigger picture. It's one of those upstream factors that leads to outcomes related to social determinants of health. So healthcare access and quality, cultural and health-related beliefs, behaviors, so culturally appropriate tobacco use in different groups, for example. Less so for pediatric cancer incidence, but could be effects in terms of survivorship. When we think about psychosocial effects, so effects of stress and the bigger picture of your sociodemographic or income related factors for families, biological epigenetic factors, environment, things like air quality, housing, transportation, distance from treating centers, all of those features, as well as education, employment, for example. All of that feeds into cancer health disparities, so the development of cancer, risk reduction, early detection, treatment, and survivorship. And as well, a big factor that we haven't touched on yet is the lack of diversity in cancer research and the care workforce. That certainly is a piece that we are focused on here at the CPCC and ACCESS, and that we need to think about as well. And all of these feed into adverse health outcomes. So as we've been thinking about the work we're doing, we are looking at various frameworks to say, how are we going to build something that can build a little differently? And one of the really nice frameworks we were looking at was the recent framework that came out from Ontario Health, where they're talking about collecting, reporting, and using equity data, embedding that in a strategic plan, partnering with community members and Indigenous members in particular here, but beyond that as well, and investing in this implementation, with the hopes that that would reflect and represent the community, engage our key voices, address racism, reduce disparities, improve health across the spectrum of experiences, report back and be able to feed back to drive new changes and identify clear accountability. Then additional frameworks that are really important that I think if you're going to engage in any of this work, you need to know and understand. And the first one is OCAP. And so this was developed by First Nations in terms of engagement with data related to these groups. Now, for many folks who may not have thought a lot or who have just sort of been stuck in academia and haven't engaged much with Indigenous partners, we have to recognize that Indigenous folks have lived here since time immemorial. If we think about each of these groups as their own nation state, I mean, you think about Europe, for example, if someone went to Europe and took over the whole place, you'd still be existing within the structure of ongoing current nation states. And that's how we have to think about our First Nations, so that each nation individually is a representative. You have to engage individually with each of the First Nations that are near you. And these groups do have a right to ownership, control, access, and possession of their own data. So if you are collecting information on First Nations participants, as we are, we're building a committee with the Social Justice, Indigenization, and Inclusion group with an Indigenous Research Council to help us with reviewing and advising on data related to First Nations, Inuit, and Métis participants. The next piece was that the Black Health Equity Group in Ontario looked to OCAP and said, we would really like something similar. And they built a data governance framework for health data collected on Black communities in Ontario. And we're requiring engagement, governance, access, and possession of the data similarly. So here within our group, we're aiming to build representative stakeholder groups to advise and review on research involving other equity deserving groups. Subsequent to building, we have to start somewhere. We're going to start with our Indigenous partners first, but we would like to be able to do that in the work that we're doing moving forward. Following that, we have reviewed leading practice documents, and I'm putting this here for you guys to take a look through as things that are worth really delving into and reading. So the first one on the far left side of the screen is the guidance documents from CIHI on collecting race-based and Indigenous data. So if you're looking for example, demographic categorization, this is a nice, well thought through, well integrated with community approach that I think is worth consideration. On the far right of the screen was a guidance document just put out from ICES on anti-racist approaches to research. And so for folks who are engaged in research, I really would suggest you take a look through that in terms of an approach to how you engage with families and folks across your whole network. But the one in the middle is recently published from the CMAJ in terms of guidance on the reporting of race and ethnicity in research articles. And I've actually blown up this a little bit more because it's an easy to read 2-page document that we at the PCC or at ACCESS are requiring folks to consider in terms of the projects that you're putting forward and when you go to report your projects in terms of how to go about reporting it. So the first piece was in terms of encouraging collection of race and ethnicity. It's really important to do this so that we can provide evidence on this disparities. We know that disparity exists and we don't really know why. And we really need to delve into why this is so that we can build advocacy and try and combat these disparities. And while it's recognized that race and ethnicity are social constructs, they really interact with other sociodemographic variables and the experience of racism that people have in the health context. So this is really important as to why we're telling you when you are submitting us things, you have to go back and you have to think about EDI principles. So this is why we want this data collected. But if you're going to collect data on diverse patient partners, you need to include representation of those affected. We need people to come in as study partners, co-investigators, and authors. And those even who aren't participants because they are representative, they really need to comment on their own social location. So Carolyn and I did that today, and even within articles, you need to be able to do that. With regard to your methods, race and ethnicity really need to be self-identified. It can't be identified by somebody else. You have no idea who someone is. So when folks are trying to collect this data, you can't just pull it from the chart. It really has to be a self-report. If you are listing that in terms of categorization, you really need to describe the categories you're using and if multiple options were available. And it has to be reported with other sociodemographic variables. When you're interpreting your data, you should provide commentary on the intersection with other sociodemographic factors. And note that race and ethnicity can't be used as a surrogate for genetic variation or ancestry. If you want to study genetics, you need to study genetics, because this really being a social construct is more about sociodemographics and racism and those social constructs than it is about what your pharmacogenetics is, for example, and no race-based algorithms. So there are a few in existence, and really all of those folks are calling for an end to those things. For example, blood pressure measurement and difference by race. And really then the biggest piece is that your work has to be conducted in a non-stigmatizing manner. So when you're reporting it, you don't want to have a racial hierarchy, meaning white shouldn't be automatically the first thing that you list. You really need to list it in some sort of order, either alphabetical or by prevalence or something that appears to make sense. You really want to use precise language when you're describing racial groups. And if you need to combine racial groups, you need to describe your rationale. You can't just put things together because they're the leftover ones. And names need to be capitalized in an adjective form, for example, Indigenous peoples. And so how are we embedding equity into the work that we're doing? Well, first and foremost, people with lived experience are participating at all levels of the work that we're doing at the CPCC. We have surveyed our members and have goals for representation across the population, so that the population of people who are leading the CPCC and leading the work that we're doing are actually representing our families and patients. We have an approved organizational equity statement that Carolyn will share with you in just a second. We've established the Indigenous Research Council, and we're starting to do work in that regard. We do equity review of all the proposals into the CPCC or ACCESS prior to funding these. And we provide guidance and support for patient-level sociodemographic data collection.
So finally, I just want to talk a little bit about the equity statement. And the importance of having one as a really young organization. When we kind of proposed this equity statement to the transition team, it was to talk a little bit about what do we want to be as an organization, and who do we want to attract as part of an organization. And one of the cells I had talked about was, in my previous role, I had actually done a review of various equity statements, and consistently those that are providers of care to either newcomers or highly racialized groups have an anti-racism statement up front. And I think they do that as like the first step of saying that this is a safe organization for which you can participate. And also it gives an idea of, without having a strategic plan, the type of work that we want to do. So I'm really quite actually proud that the transition team approved this statement. And I do want to read it because I think that that language actually does matter. So we're going to change it obviously to ACCESS at some point, but it's a partnership of clinicians, researchers, policymakers, advocates, patients, survivors, and families across Canada. It embeds a patient and person-centered approach by directly engaging and collaborating with persons with lived experience. That's what Stacey had talked about across all levels. The CPCC is committed to upholding the values of reciprocity, equity, and human rights in our work to build a national pediatric cancer strategy. As individuals of the CPCC, we come to this space to share responsibility for creating a diverse, inclusive community that strives to improve pediatric cancer outcomes while simultaneously working to reduce barriers to treatment and outcome inequities. And the CPCC, finally, is committed to addressing systemic inequities and recognizes systemic oppressions based on, but not limited to, Indigenous identity, race, socioeconomic class, gender identity, sexual orientation, immigration status, religion, age, and ability. So in closing, the last things that we wanted to talk about, mainly because the CPCC so far has been about its research grant. And it might sound repetitive, but for those of you who are doing research and not necessarily clinical care, I feel like the first section was a little bit more in clinical care. As again, you heard from me, you heard from CMAJ, you need to start with yourself and socially locate yourself, and in comparison to who your research participants are going to be. I'm going to ask you again to complete some trainings on cultural safety, but you also need to think through about how does OCAP, there are a couple of videos out there, there's not tons, but you'll need to spend some time in understanding what does OCAP mean, read through the documents. But there are, again, if you Google it, you'll find a few good videos about how to actually implement OCAP. And finally, how to collect sociodemographic data. You can say that you want to collect sociodemographic data, but it does actually take some effort, even after you want to do it. We talked a little bit about standardization of race and other sociodemographic data in your research project. So one of the first questions I had for Stacey is, okay, so you guys collect, as parents or as patients, you get asked a lot about your child or yourself if you're the one, if the child is old enough to consent. Where does that actually go and how is it coded? And what Stacey said was, it's a real mishmash and it's a mess. It's not great data. And I think what we would like to do as part of this consortium is to really start small and figure out how do we actually get good data. So we talk about these inequities and outcomes. I want ensuring your research team is trained on equity-based research principles. That CMAJ article, ICS just came out with a nice document as well. There's like no shortage of documents to kind of think through about how do I provide good equity-based research principles. And then again, anybody who's actually going to interact with a family or a patient really needs to be trained. And finally, and Stacey says this is actually Stacey's words, she says it all the time, to remember that good intentions do not prevent you from doing harm.
I do say that all the time because I think all of us in the pediatric cancer space come to this work, come to our jobs because we love what we do and we want to do good. We want families to have the best of the nightmare of their life. And none of us would come to this work to hurt families and kids. But that doesn't prevent us from actually doing it. And through this work, I have heard how we all have intermittently done it. I've heard how I've done it. And I feel so much gratitude to the people who had the faith in me to be able to say, I wish you had done this differently, because then I can learn. And so I feel like it's a real privilege to be told you could have done this better, because then I can use that to do better in the future. And I would hope that you guys can all reflect on that and consider that as well, that it's a real privilege to be able to be told, you screwed this up. So on that note, thank you all so much for coming. There is a QR code to a short review of our session today. We would love to hear about what you would love to learn about subsequently. Carolyn and I spent a lot of time thinking through the depth that this presentation should be at. And for some folks, I'm sure this was all old and repetitive. And for some folks, this may be relatively new. So we were trying to sort of start at a 101 kind of place, but would be happy to come back and sort of take the next steps with you as well. If you are looking to reach out to us, you can get us through the CPCC office email address, and we would be happy to reach out to you. And the Q&A is open for discussion. And if folks have questions that you'd like to ask by putting yourselves on audio video, we would be happy to answer them that way as well. I'm going to stop sharing so that we can hopefully take a moment to see each other as we have a bit of a discussion. So if anyone wants the QR code, jump on it now, and then I'm going to close it down. Nelson, I see that you have a question.
Hi, everybody. Thank you very much for this talk. It was really, really interesting. I'm a pediatric surgeon at St. Justin in Montreal. I took a screenshot of the neuroblastoma breakdown by ethnicity. I think these are very, very interesting concepts that are, like you said, they are impacted by the quality of the data that we're collecting. So I have two questions. One is, what is the best way to look at this data in Canada? And I know it varies by province because each province has its own, governing bodies as it relates to healthcare. And so that's my first question. But more importantly, and you've mentioned some of these, but what should we do to improve this? I think it's been established that it is an issue. How do we make it better? How do we close the gap in the outcomes of these patients on these Kaplan-Meier curves? And that's what I'm interested about. Where are we going with this? Where's the future of improving this aspect of healthcare? At COG, they were mentioning, we're trying to find new drugs, find new ways of treatments, but there is a immense, I think, potential for improvements in the quality of what we're doing. So I'd be curious to hear what are your thoughts about how we should improve in the future. You talked about a lot of how we should conduct the research right now, how we should include this information so that we have a better picture. But my question is one step further. How do we improve this? Do we have outreach people? Do we, I'd be curious to hear you about that. Thank you so much. Again, this is really, really interesting.
Thank you. That's a great question. And Carolyn, I'm going to let you weigh in as well. But I don't think we have those answers yet, to be honest. Like, I think we in our minds have a sense of, at each of our institutions, things we can do better. So for example, at my institution, I came to a lot of this work because of the experience of a couple of Indigenous patients that I had the honor of taking care of, who had an experience that they wouldn't have described as being ideal for them. And since their care, we have really engaged with them, with our community, to say, how can we improve the experience here at the McMaster Children's Hospital? And so we've developed a space actually named after one of those kiddos that is a room for families where they can be together, they can conduct ceremony, they can have medicine, that there is a space for families that they can sort of feel like they're at home when they're stuck at the hospital for a really long time. And that kind of feels like a bit of a retreat away from your room. Our team has really engaged in cultural safety training. And I think that's a big piece. But from a a research perspective, I think we need to engage with families. One of the pieces is we need to collect the data properly so we can actually know, is this real? Because we know in the Canadian data set, like, yes, every province does it differently. Across Ontario, each of the centers do it, and then they feed to POGO, and that all feeds to ACCESS-ACCES, and every province feeds to ACCESS-ACCES, but we know that data is really spotty. And it's collected differently in different places. There's some provinces where First Nations folks have a different health number so that they can really be identified, but that's only, that's not universal. And so I think across the board, we need to start all asking our families to self-report identity, and then we need to collect it. We need to train our teams to do it so that people feel comfortable self-identifying, so that we know we have the right data as a starting point. And then I think we need to engage qualitatively with families and ask families. And this is where I'm going to put this to Carolyn to say, you know, as a person with lived cancer experience, what are some of the things we need to think about when we engage with families?
So I took a couple of notes down. Yeah, so I kind of bucketed them. And I kind of changed my slides a few times. And I know I talked fast because I had a discombobulating day in my actual paid job. But I think the first one is the individual care, right? So as you as clinicians or as nurses or other health providing professionals, how you interact with the family, I think, is important. And I know I go on about the Power Flower at SJII. We had a big discussion about this, about whether we do it in December. But I really feel like we talk about, as health caring professionals, of doing self-reflective practice, but we don't actually take the time to do and think about what it means. So I know when I was at Sick Kids that I held a lot of privilege, even though I look the way I do. I don't have an accent. I'm not visibly, I don't sound like an immigrant. My parents came almost every morning. So it looked like, you know, this is a well cared for child. People knew that I was a dietitian because, of course, one of the questions they ask you is, what do you do for a living? And so right away, when people would come in, oh, you're the one that's the dietitian, right? So already I got different agency compared to another parent, regardless of the fact that I'm not even a clinical dietitian, right? I'm like a public health dietitian anyways. The second one is around the collection of data. And this is where I actually got excited. I got hopeful because when Stacey said, what are we going to recommend? I'm like, oh my God, I'm going to have to go through these like documents again. And then I saw the CIHI document. And if you didn't have any choice, I would say the CIHI document is not bad. So the CIHI document is pretty similar to the one that we tested in Toronto years ago. It's pretty similar to the one that Toronto Central and mandated hospitals to do. It's pretty similar. They're actually the ones that are used by the Ontario Anti-Racism Directorate. So now we got some consistency. And that was the purpose of the pilot 10 years ago, was that we knew that the categories that StatsCan uses for visible minority sucks, and that we needed something. So that was the whole point of this pilot 10 years ago, is to get us trying to come to some, they're going to be off a little bit because every organization is going to have to tweak it a little bit, but roughly, if we're landing roughly around the same spot, we can start comparing apples to oranges. Because right now, based on what my conversation with Stacey is, we've got like apples and plums and bananas, like we got a lot of stuff going on in there. So I think that's the other aspect of, like, when in doubt, I feel like CIHI document is really good. Stacey and I, because we both have day jobs, get our heads together. We have like a working document around data collection as well that we want to at least provide you with some good guidance. There are some good documents. That's what that guidance document would say, is like the City of Toronto has like a data for equity strategy. It has like a lot of steps on how do you actually collect this data. I don't feel like people should have to reinvent the wheel when people put a lot of thought into this already, and you just have to take a look at those documents and adapt them. I saw your hand go up. I'll stop my little. Okay.
No, that's great. And it's the truth. Like, I think go ahead. Nelson, were you gonna add something?
No, it was just a thumbs up. Thank you so much.
Oh, no problem.
Sorry, it wasn't a virtual thumb up. I should have done this, but I did this instead.
Both are good. Both are good. I'm used to some people waving at me when they have more to say. We see a couple of other questions in the Q&A, so we still have a few minutes. Stephanie Reed asked, does the hospital work families have access with or to Indigenous doctors, social workers, researchers, and medicine healers? Here at MAC, we're very lucky. We live very close to Six Nations, which is the biggest reserve community in Canada. And there is a huge Indigenous research, the McMaster Indigenous Research Institute. There's an Indigenous Studies program. There's a whole ton of work across the Faculty of Health Sciences. So there's tons that we have available to us here in terms of folks. Now, that being said, within pediatrics in Canada, there are, I think at present in training and finished training, perhaps 4 Indigenous pediatricians, and that includes subspecialists. So there are not that many people. A lot of folks come to their cancer journey and say, oh, is there an Indigenous oncologist that I could talk to? And no, there isn't in the Canadian context. There's a lot of work that needs to be done on the front end to really encourage a diversity of healthcare workforce folks who could be representative to families, because there are folks who say to us, had someone from my ethnic background approached me about a study, perhaps I would have considered it, but I didn't really trust it based on my mistrust in the health system. And so I think this is something we need to be cognizant of and continue to build. So I think that there's lots of work going on. I think that there are people you can reach out to, but I do think it's important at each institution that you figure out who your local community is. Like if you want access to healers for families who may not know that part of their history yet and may not have engaged and may not have a healer that's available to them. If you know folks, it's really helpful, and it really builds trust with families to say, well, I actually know somebody from the community I could reach out to, and our team knows somebody. And that would be great, but that really has to be done individual to individual, and it requires years of engagement. So if you haven't started engaging yet, I would suggest you start now. Stephanie, did you want to add anything to that? No. Okay. Then, and Carolyn, did you have anything to add to that? Then another participant asked one of the tricky CPCC access questions that I think is really super relevant, is that if geography, power, and privilege are components of equity, access is housed in Toronto through SickKids, where disparities and differences maybe aren't as tangible, and how do we as a community work through that? This is something we have thought a lot about. I am not in Toronto, but I am close in Southern Ontario. And many of us and many of the pediatric oncology centers are along sort of the American border. And there's a whole lot of Northern Canada that's north of us that don't have the same access. We in the SGII group are working to engage with folks, families, providers across our geography. Yes, while the home of the money is in Toronto, we're trying to really engage on a national level. So we're working on that, but I do think that's something we always need to keep front of mind. Carolyn, I don't know if you have something to add to that, or Christine, I see you're on. I don't know if you have something to add to that either.
Maybe I'll just add one quick thing, is that yes, we've recognized this as a challenge, and the two, because CIHR required a PI to be named, there are actually 2 PIs and they're both at SickKids. So that's something we can't undo, at least at this phase. But one important thing we can do is change the governance so that it is more reflective of the whole country. So we're in the midst of doing that right now and setting up a senior leadership committee, which will be the most senior advisory or decision-making body for the consortium, and that will have much better representation of geography, making sure we're balancing gender, career stage, people with lived experience, etc. So we are trying to address it where we can in terms of committee structures and governance.
You're on mute, Stacy.
Sorry, there was a code red drill, and so I turned my thing off, forgetting to turn it back on. Wondering, I know we have lots of learners on the call as well, wondering if anyone in a training capacity had any questions about how do we engage this work, or questions that you have from a training perspective.
Sorry, can you repeat the question?
Yeah, I was just wondering, in terms of other questions, if there were any learners who were on, who are wondering, you know, are there things from your training or from a training perspective that you were wondering about, how do we do this, or how are we engaging this, or have you learned any of this up to this juncture?
So I'm currently a psychology student at the very early levels. I'm in my third year bachelor's degree, and I think that this has been extremely helpful for me, just in terms of getting to know what resources are out there, as well as the definitions that you provided at the beginning, because we do hear a lot about like social determinants of health and all these other concepts, but it's not always very clear. And so this has helped me in that sense, and I'm really looking forward to taking a look at the different links that you provided, and just overall hopefully being able to implement this in the future work that I do. So thank you very much.
That's wonderful. Thank you. Excellent. Well, barring any further questions, it's 4 o'clock, so we'd love to give people back the next hour of your time. We're happy to stay on for a few more minutes if there's any folks who have any additional questions, and looking forward to future sessions with you as well.
Thank you. That was great.